Good afternoon, almost everyone. Thanks for joining us today. My name is Tatiana Wheeler, and I work for the organization that sponsored today's training. We are Heading Home of South Central Indiana. For those who aren't familiar with us, we are a regional initiative working to make homelessness rare, brief, and non-repeating. So we are working to strengthen our homeless response system in a 6-county region, which includes Monroe County and a few surrounding counties as well. With that being said, I just wanted to give a little bit of background context of how Heading Home is working with the veteran population specifically before we get into today's training. So in May of 2022, Heading Home created a regional team to join a national initiative called Built for Zero. Built for Zero partners with communities to equitably end homelessness, one population at a time. So we have Built for Zero coaches or consultants that are helping us make system improvements to our homeless response system to more rapidly house people and to make sure that homelessness is rare, brief, and non-repeating. Built for Zero encourages communities to look at homelessness population by population. Many communities start with their veteran population because veterans have a lot of resources available to them. So in January, actually, of 2023, Heading Home and regional providers, including HUD-VASH, including Veteran Affairs, Veteran Service Officers, thank you to Steve Miller for being here today from Monroe County Veteran Service Office, and the emergency shelters in our region started gathering and holding what's called Veteran Case Conferencing, which is an interagency biweekly meeting when all of these providers are talking about the veterans in our region experiencing homelessness and how we can reduce their barriers to housing. Since beginning this initiative in January of 2023, we've been able to house 41 veterans in our region, which is something that's worth celebrating. So yay to all of those agencies, those organizations that have made that possible. And we just wanted to also share with you all that while we are, working to end veteran homelessness, that really we're really wanting to improve our system to make sure that no veteran finds themselves unhoused. So we want to make sure that veteran homelessness is, like I said, rare, brief, and non-repeating. So our community and our region is working to end veteran homelessness by August 31st of 2025. And if you want to know more about what that looks like, please see me later. But without further ado, if you would like to learn more about Heading Home, our other work, and our other projects and initiatives, you can scan this QR code to sign up for our newsletter and stay connected to what's going on. But we're happy that you're here. Your presence means that you care about people, and the world's a better place because each of you exist. So we look forward to today's training. If you need contact information, here's our website, here's my email. But without further ado, we're really excited to have Jesse Schwartz with us today, who is our guest presenter for this training. So without further ado, let's welcome Jesse.
Thank you, everybody. My name is Jesse Schwartz, and I am a social worker with the Indianapolis VA Medical Center. I'm a coordinated entry specialist, which essentially means I work with the different homeless response systems. I work with Balance of State specifically, so I'm working with some different communities in central Indiana, Bloomington and Region 10 being one of them. Also working with Lafayette and Terre Haute, Columbus, and some of those other donut counties around Indianapolis. What we are here to talk about today is suicide prevention, and I want to thank all of you for being here to talk about or listen about this important topic. I do want this to be interactive. I know this is a little bit bigger of a room, but I hope you all feel comfortable raising your hand if you have a question or if anybody has an experience that they want to share, or if anything that I'm saying brings a thought or something that you want to share with the group, that would be wonderful. So just to start, has anyone ever attended a VA SAVE training before? Anyone raise your hand? Okay, great, but most of you have not. Essentially, the VA SAVE training is known as a gatekeeper training for suicide prevention. So we offer this training to anyone and everyone in the community who may have interaction with veterans. The risk of suicide for veterans is higher than the general population, so that is why the VA considers suicide prevention and this topic so important to discuss. But essentially, with this topic of suicide prevention, with the things that we're talking about today and the different skills that we're going to review, these are things that you can use with any person in a state of emotional crisis. They do not have to be a veteran. We will review some data that focuses on veteran suicide specifically. But just keep in mind, the majority of this presentation is applicable to the work that you all do in your professional life, also your personal life. We deal with emotional crisis everywhere. So hopefully you find this helpful and relevant, even if you don't work primarily with veterans. Is there anybody in this room, I recognize a couple, anybody who's primarily working with veterans? A few? Okay. And then the rest of you came today because you're interested in suicide prevention and this topic, which is wonderful. So why are we doing this training today? Suicide is a major public health concern. And as I said before, it's a particular concern for veterans. VA is a leader in suicide prevention. However, most veterans who die by suicide are not enrolled or engaged with VA care. So that's one reason why the Save Gatekeeper training is so important, because it's a tool for reaching more veterans through caring individuals like you all who are here today and can assist those who might be at risk. So as I said before, keep in mind we will be speaking directly, about veteran suicide in this presentation. However, remember that the SAVE techniques can help save all lives and not just veteran lives. So even if you don't primarily work with veterans in your day-to-day practice, you can use these skills both professionally and personally to assist those who might be at risk of suicide. So just a reminder, we understand that suicide is a sensitive topic. So if at any point you feel the need to leave the room or take a break, that is completely understandable. Feel free also to reach out to me at the end of the presentation, whether it's today or at a later time. If you want to reach out and review anything with me, that is okay as well. So the SAVE training is focused on preventing suicide attempts and saving lives that might otherwise be lost to suicide. It is designed to train everyone who knows a veteran to be a gatekeeper. So the role of a gatekeeper is connecting those at risk for suicide with people who can help them. You can save lives by both being sensitive to people in distress and connecting them with care. So just remember those are very human-focused skills where we can all be sensitive and care about others and be motivated to connect them to care. And it doesn't take any special education or additional training in order to do that. I also like to think of training such as the SAVE training as similar to, say, CPR training. Some of you may have to do that as a part of your jobs, or maybe you've just done that on your own. And you might know when you do CPR training, in order to maintain your certification, you go and you review those skills every couple of years. At the VA recently last year, we started to do a RQI training, which has us do skills refresher for CPR every 3 months. So we go to the mannequins every 3 months and we're doing some online skills refresher. The idea behind that is the more you're exposed to the material and the more that you practice, the better that you can be when you're in a crisis situation. So I'm not suggesting you all attend a SAVE training every 3 months, but we do recommend that these be done regularly. We have some VA partners, community partners, who receive some VA funding to serve homeless veterans. And it's a requirement in their grant that they do a SAVE training once a year, just to maintain those skills and keep them fresh for those who are interacting with veterans. So if you feel like this training is useful and you maybe don't get this training in other ways, I'm happy to present this as often or in as many places as people would find it useful. Just feel free to reach out to me. So a little bit of an overview of what we'll talk about today. We'll talk about some data and some facts about veteran suicide. We'll discuss some common myths versus realities. and then the steps of VA SAVE and what it stands for, and then also some resources. Out on the table, just on your way out, if you didn't grab anything, I did print off a page that's a nice flyer that reviews those SAVE steps and the techniques and provides some tips. So that might be helpful to put on a bulletin board or have in your office if you'd like to have that. I also have Veterans Crisis Line cards that are on the table. Feel free to take those. I can always get more from our suicide prevention team, so take as many as you'd like, and if anybody has a request for more materials, just let me know. And then I also put some gun locks out on the table, and those are for you to take as well. So just some objectives by participating in this training. You will have a general understanding of the scope of veteran suicide, know how to identify a veteran who might be at risk, and then also what to do when you identify a veteran, or again, any person who seems to be at risk of suicide. So I just wanted you to take a moment to consider. Nobody has to raise their hand if they don't want, but just think for a minute. What are your biggest questions around suicide and talking to those who are in emotional crisis? Just take a minute to think about that as we get ready to go through the material. Okay, so I will go through some of the data about veteran suicide, and I want to be sensitive to the fact that numbers represent people, but I know that it may seem uncaring or insensitive at times to think about suicide numbers as numbers and not humans. So I will not talk too specifically about the actual numbers. You'll be able to see those. What's more important is to think about the trends, and we'll talk a little bit more about that. So speaking of trends, suicide is a national issue, and there are rising rates of suicide in the general population. For every death by suicide, approximately 135 individuals are impacted. And I just think that that is a staggering number when you think about one completed suicide impacting so many individuals in not just family, but community members, co-workers. It's quite broad, the impact that that can have when that happens. So that is why this presentation and this topic are so important, because as many as we can prevent, and that impact not just to the person who completed suicide, but the broad rippling effects of the impact that it has on the broader community. So there are various factors that that can impact the rising rates of suicide. We have societal factors such as economic disparities, race, ethnic, and LGBT disparities, homelessness, which that's something that I work with closely, a lack of social connection and also isolation that people are experiencing, and overall issues with health and well-being all play additional roles of impacting these rising rates of suicide. And of course, as you might expect, the COVID pandemic definitely has impacted these rates as well. Looking back at some prior presentations, they update these slides for us a couple of times a year, so that the numbers are up to date. But in looking at some past presentations, I can see the data trends. There was a big drop in suicide from about 2005 to about 2018. So that was encouraging, though it does appear since that time there has been a rise in the last 5 years. So those numbers are trending up slightly. So just some high-level data points, and this is regarding veteran suicide specifically. I'm sorry I don't have a slide for the general population. So I won't read these numbers specifically, but you can see there, this is the data as of 2021. So even though these slides were updated about 6 months ago, the data is about 3 years behind. So it does take time to calculate these trends and suicide rates. But one thing to keep in mind, and the reason that there's an entire Office of Suicide Prevention at the national level for the VA, is that for 20 years, from 2001 to 2021, the adjusted suicide rates of veterans did exceed those of non-veteran U.S. adults. So suicide, it is a complex issue, and there is no single cause. It is often the result of very complex interaction of risk and protective factors at the individual level, but also community and societal levels. Risk factors are characteristics associated with an increased likelihood of suicide behaviors. Now, that doesn't necessarily mean it's a cause and effect relationship. It's just when you see an interaction of risk factors with an individual, it's something for you to be heightening your senses and your awareness of maybe additional concerns that are going on there with their emotional health. And of course, protective factors, if there are a number of those or even a couple of very strong protective factors, they can help offset that risk. So with veteran suicide, or for anyone at risk of suicide, we want to maximize protective factors and we want to reduce the impact of risk factors. We may not be able to take away completely a risk factor that is there for someone, but if we can minimize the impact of that, and maybe you won't specifically be doing that, but just being connected with resources in your community and being prepared to connect individuals to help is a good start. So we'll go through a little bit about some examples of some risk and protective factors. Definitely a big one would be prior suicide attempt, mental health concerns, substance use, economic issues, relationship issues, homelessness. And then some protective factors would be maybe they do have mental health concerns, but they are connected to mental health care, or they have access to that, or they've discussed a willingness or an interest to engage in services, problem-solving skills, a connection to spirituality or religion, feeling a sense of purpose or mission in life. At the VA, as clinicians, when we have a clinical interaction with a veteran, we have built into our templates a full suicide risk assessment every time we meet with them. And we literally have a list of common protective factors, common risk factors. We are identifying those in those interactions. We're documenting what we observe with that, and then we are classifying both an acute risk for self-harm or suicide, and also chronic risk. And we're classifying that as low, medium, or high. And then the VA will train us and give us recommendations depending on what that is assessed as, what next steps potentially should be, and maybe some additional assessments and prevention safety planning that we can do with that veteran. So it's very built into our work with veterans at the VA. This training is not intended for you all to get to that level, but I just want you to know, for those of us working with veterans in the community with our services, even if they're not healthcare eligible and maybe they're working with our VA homeless programs, we are asking these questions and we're assessing this because they do impact a lot the overall risk for that person. This is a section that was added in more recent years to the SAVE training, discussing access to lethal means, because it is a huge risk factor for a potential suicide attempt. And also there are things that can be done related to lethal means safety planning that can really hopefully reduce risk for that individual that may or may not have access to lethal means. I did also print off a brochure about lethal means safety planning that is out there with the other materials. If you all would like that, it may have things on there related to veterans, but just remember those are some tips and some safety plan ideas that you can use with anyone. So a little bit more data about U.S. veterans and suicide methods. So you see suicide methods for veterans. This is in 2023, and then non-veteran U.S. adults. So the biggest change there that you can see is that firearms are more commonly used by 20%, which is a very wide margin, by veterans versus the general population. So what is lethal means safety and lethal means safety planning? In the context of suicide prevention, safe storage of lethal means is any action that builds in time and space between a suicidal impulse and the ability to harm oneself. So the two key words there are time and space. When working with someone who might be at risk for suicide or has that history of perhaps a suicide attempt or intense suicidal thoughts, and they have access to lethal means, let's say they own a gun, and owning a gun is very important for them. The goal is not necessarily to inhibit their access to that if they use a gun maybe for hunting or hobby or protection, but it's having that dialogue with that person about how they can maybe reduce access to the gun when they don't need to use it or at a time when they might be thinking of harming themselves. So we want to respect the role that the individual has with access to their firearms and maybe medications, if medication is a method that they've considered, and be consistent with their values and priorities, and also keep safety in mind. So a couple of examples that I have heard that have been helpful. One time at a training, I heard about a veteran. So you may have heard some people use a gun safe, for instance, and then there's a key that can maybe be used with a lock or maybe a gun lock for the gun. So one person who knew they had a risk for suicide, they did something where they had a cup of water and they put the key in the cup and then they put it in the freezer. So it was essentially frozen in a block of ice. So what that did is it really focused on the time issue. So yes, there are things you can do to get that key out. But if you are increasing the time and how long it takes to access that key, that could be really crucial time where someone has to reconsider what they're thinking. If it's an impulsive behavior, there is more time built in to where maybe they can reverse course. There was another example that someone gave at one of these SAVE trainings, actually, that was useful. They said that they had a veteran who, again, knew that this was a concern for them. And so they took the time to disassemble their gun. They were confident enough with guns. They knew how to put it back together, so that wasn't a concern. But it would take time to do that. And that was important for them to extend that time that they would have access to a gun. So some of this is individuals who we work with knowing their own risk. And when they collaborate in these discussions with us, if we have the opportunity to do that with them, they can have some really good ideas for themselves on what works for them. We always want to start there, what works for the individual. If they have a long history of suicidal ideation or perhaps hospitalizations, they have had a lot of training in safety planning and they know what works and what doesn't work. And so starting there with them in that conversation. So a little bit more to reinforce what I was saying about time and space. So this is data showing how most suicidal crises are brief, and oftentimes it is less than an hour from when that impulsive thought, if it gets to that point of thinking I want to kill myself, it can be within the hour that happens. So some of these lethal means safety techniques and lethal means safety planning, if you can extend that time and make it harder to access the lethal means, it can really save lives. Other people, it can be something as simple as if you have a trusted individual where you can leave your gun maybe at someone else's house. And that trusted person knows that you maybe have that risk and that you want them to hold on to it. So there would be that barrier and that layer as far as accessing that lethal means. And, in talking about veteran suicide and the fact that veterans are more likely to use firearms, also you can see here from this graph that firearms are by far much more likely to be lethal and for it to be a completed suicide compared to other methods. So again, still 50% of the general population is using firearms as well. So it's a critical issue for non-veterans as well, but for veterans because they are using it more often with more frequency and it's more likely to be fatal. That's why the discussion of lethal means safety and access to lethal means is so important. I think it's been in the last several years with our suicide prevention safety plans that we create with some veterans. They have added into the template a section specifically about lethal means safety. And we are assessing what access they have to lethal means and including a section in there prompting us to have a discussion with the veteran about how that looks for them, anything that can be put in place to help reduce that access to lethal means, particularly when they are maybe recognizing some warning signs in themselves that they are not well and that they are at higher risk of having a more severe emotional crisis that could lead to suicidal thoughts. Sorry about that. So just to put a period on this topic, lethal means safety does work. And it's one of the few population level interventions that has been shown to decrease suicide rates. Also another number you see there, 90% of people who survive a suicide attempt do not go on to die by suicide. So that is unfortunate that someone has gotten to that point to attempt. However, it's also an opportunity if they survive for there to be intervention and additional support for that person to help them move on from that experience in a healthy way. So if we can collaborate with veterans, and again, the key word collaborate, we want it to be collaborative. We don't want it to be perceived as someone telling someone what to do. This is meeting them where they are at, seeing what their concerns are, and having a conversation about what steps or ideas could be put in place to help prevent suicide for them. Suicide is preventable. Okay, so a little bit, my goodness, so sorry. A little bit about common myths versus realities with suicide. So even though suicide is a major public health concern, there are a lot of common myths and misinformation that swirl around about suicide and suicide risk. So having accurate information makes it easier to reach out to others and help them. And so I just want to give a couple of examples of some common myths and then discuss what the reality is. So, has anyone ever heard this? People who talk about suicide are just seeking attention. Yeah, I see some heads nodding. And maybe even sometimes if we've worked with individuals where emotional dysregulation is common, I'm sure maybe we have all had that thought ourselves about a particular client, maybe some doubt as to whether this is a legitimate risk for this person. So that's a common myth. The reality is that no matter how casually or jokingly said that suicide threats should never be ignored and may indicate serious suicidal feelings. And just remember that when someone talks about suicide, it's an opportunity to intervene. before suicidal behaviors occur. If I'm talking with a veteran and they're expressing some distressing feelings, some feelings of hopelessness, that's an opportunity for me to ask more questions, for honestly to listen. We talked earlier at the beginning about how this training is a reminder that we can all be caring and make a connection with someone. So whether you may believe that this is an actual risk factor for this person, that they are at risk of suicide, they are opening the door that they are in distress and they need to talk about that. And you can assess further in talking with them whether or not this is truly an immediate concern or not. So we always want to take it seriously and always talk it through and ask more questions. So another common myth is that the only one who can really help someone who is suicidal is a mental health counselor or a therapist. Anybody else heard that or felt that way, that that is someone else's job to discuss? And I alluded to this in talking about the SAVE training as a gatekeeper training. Special training is not required to safely raise the subject of suicide. Helping someone feel included and showing genuine and heartfelt support can also make a huge difference during a challenging time. If at any point when you're engaging with someone who is expressing thoughts of suicide, we're going to talk a little bit about intervention and ways to connect individuals to help. There are a lot of warm handoff opportunities, I'll say, where you can get assistance and support if needed. Depending on your comfort level, the situation, other contexts of what's happening around this situation. There's always opportunities to get support if you are engaged in a situation where suicide is a concern. But just know that we're all able to make that human connection and be there to support someone. Okay, so we will talk a little bit now about what SAVE is and what it stands for. So the VA SAVE training, this is a training that is sponsored by the VA Office of Mental Health and Suicide Prevention. And as I've said before, it's teaching communities how to help veterans or other individuals at risk for suicide. So the steps of SAVE that help you act with care and compassion if you encounter someone who's in suicidal crisis. So S stands for the signs of suicidal thinking that should be recognized, and we'll talk more about those. A is ask the most important question of all, and we'll talk about a little bit about how to ask and some do's and don'ts with that. V is validating the veteran's experience or the individual's experience if they're not a veteran. And E would be encouraging treatment and expedite getting help. So we'll talk more about each of those steps. So some signs of suicidal thinking, and so, these may seem obvious to you, but I think it's important to review them. And like I said, I have a flyer out there if you want to have that to just remind yourself of some common signs to keep in mind when you're speaking with someone, whether it's personally or professionally. So hopelessness, feeling like there's no way out, anxiety, agitation, and if you're working with someone regularly, maybe it's an increase in these things. Maybe they have a baseline of some agitation or mood swings, but it seems to be more extreme for them based on your experience with them. Obviously, feeling like there's no reason to live, having a purpose in life is something that that we assess for when we're looking more closely at suicide risk. And if someone does not have that, that can be a risk factor. Rage or anger, and again, it could be an increase if it's someone who is more prone to being angry. Being in more risky activities or increase in impulsive behavior, maybe doing things that is risky for that person, but maybe they don't care. Whether they say it explicitly or not, they're engaging in things that could harm them and not thinking too much about the consequences. And then withdrawing from family and friends, isolating. We work with homeless veterans, and a lot of individuals who we work with don't have a natural support system. They may not have family and friends, but maybe they are typically connecting with the providers at the shelter or at a resource center, and they haven't been around for a while, or they come in but they aren't talking as much as they normally would. So anything where you're seeing a difference in behavior, interaction. These are signs. Again, they aren't definite indicators that someone is contemplating suicide, but they are things to keep in mind and be aware of. So a little bit more about some signs of suicidal thinking that require more immediate attention. Definitely thinking about hurting or killing themselves, and presumably you would know this because they've told you. We call that suicidal communication. So if someone's engaging in suicidal communication and talking about how they want to hurt themselves, that is a huge red flag. Hopefully you all know that we all, just as members of society, and definitely if you're a clinician or you work as a social worker or some other capacity, we're mandated reporters. So if someone is expressing that they are planning on killing themselves or harming anyone else, but this presentation is talking about suicide, that we're expected to call the police or make sure that someone is getting engaged to emergency care for further evaluation. Looking for ways to die, so maybe they don't have an intention of killing themselves in this moment, but maybe they share for the last couple of weeks they've been researching different methods of how to die. Just generally talking about death, dying, and suicide, and like I said, engaging in some of that self-destructive behavior, especially when it involves things that has the potential to be more lethal. These are all things where you want to take it very seriously and consider it potentially an acute risk, which means very near term and someone that needs connected to help right away. So just a little bit more in talking about some examples of suicidal communication. Like I said, some examples of something you might hear someone say: I don't care what happens to me. I have been thinking about ending it all. Everyone would be better off without me. Or I don't know if I can go on anymore. So these are some really powerful statements that if you hear, if they're talking more about what's going on, they're maybe starting off expressing their frustration with something, but if they start going into some of these statements, these are indicators that they are really in a low place, and it invites you to the next step, which is asking the question. So asking the question. We'll talk about the question, but then also the how you say it is very important. And this is it. So there's a lot of different ways that people sometimes ask this question. And the important thing to keep in mind is that we want to be direct and clear, and it does not have to be long. It's a very short statement. Are you thinking about killing yourself, or are you thinking of suicide? And a little bit about the do's and don'ts, and so we'll talk about some ways not to ask the question that, by the way, are very common. If you work in a mental health agency or work around individuals who assess for suicide regularly, you will hear a lot of ways that maybe aren't the best way to ask this question. But that's why we do this training, is just for reminders. I think we have all been been someone who has probably not asked it the right way every single time, especially in all the years we've been doing this. But it's good to have the reminder of the better way to ask this question. So, of course, related to the signs, definitely do ask this question if you're seeing those warning signs. So some of those warning signs, especially not the direct suicidal communication ones, but some of the other warning signs, they aren't an indicator that someone is necessarily thinking of suicide. But that's why we ask the question, is to check and see. And by asking it in a direct way, we're setting the tone for that individual that this is a safe space, that first of all, you care, and that's why you're asking the question. And also that you're inviting them that it's a safe topic to talk about. With the don'ts, when you say something like, you're not gonna kill yourself, are you? Which I've heard some people, that's how they ask it every time. And in some ways, it sets the tone that this isn't, first of all, it's an uncomfortable topic. And that person asking it that way is very well intentioned. They are, I don't know exactly why they're asking it that way, but they maybe are a little uncomfortable with it, or they think they know the answer, and so they're asking it that way. But we don't know because we are not that individual. And when you ask it that way, it can make the person hearing that question think that maybe they might be doing something wrong if they say yes. And it can lead them to feel more uncomfortable saying yes, even if they are having those thoughts. So that's why it's important to not present it in that negative way with the assumption that the answer is no. Also, we want to be careful to not ask the question right as they're leaving. If they've already gotten to a point where they've kind of shut down and maybe they're ready to end the conversation, they are more likely to maybe not be truthful with the answer because they've already shut down and they don't want to engage in a longer conversation. So ask the question in a natural way, and also just be thinking about the timing of not waiting much longer into the conversation, because you don't know if your window of opportunity might go away. You don't necessarily want to jump on it and present the sense of urgency or anxiety along with the question, but have it flow naturally and try to ask it maybe in time with the conversation a little bit closer to where some of these warning signs presented themselves. So you can say, reflect back what you heard. Maybe say something like, I hear that you say you've been feeling hopeless lately. Can you tell me more about that? And also, are you having any thoughts of suicide? Are you having any thoughts of killing yourself because you have these feelings of hopelessness? So reflect back what it is that is concerning you as you ask the question, and that will feel more natural as a way to ask that question. Any questions so far from the audience? I've been going through these slides, but is there anything as we start talking through some of these more real life scenarios, are there any questions that anyone has about asking the question or being in these situations with someone in crisis? Okay, that's okay. Okay, so validating the veteran's experience. This one is fairly self-explanatory, but again, good to remember what it means to validate someone. Again, this could be anyone's experience, not just a veteran's. So as I said earlier, we want to be able to model the ability to talk openly about suicide. Sometimes it can be a taboo topic. It's also an emotionally charged topic. It's hard to think about. However, there are individuals out there every day who are experiencing this, and it's their reality. So we want to be able to model that ability to talk openly about it, because you don't know who you're talking to might be feeling that way. Of course, recognizing that the situation is serious, and reassure the person who you're talking to that help is available. Some ways that you can validate the veteran's experience, some things that you can say. Anyone in your situation would feel this way. Of course, you're overwhelmed as you hear them talk about all of the things that they're going through. You have been struggling a lot, and this would be too much for anyone to handle. So just a way to reflect back some statements of really acknowledging the challenging experiences that they're going through. And then the last step is encouraging treatment and expedite getting help. So what do you do if you think someone is suicidal? So first of all, don't keep it a secret, especially if they are at imminent risk that you feel of hurting themselves. It really is important to get them to help, whether that's calling 911. If you work in an agency with other individuals, maybe you are sending a message for someone else to call 911 if you can't do that. We don't want to leave him or her alone. And that's just the best practice. Just don't leave them alone. The definition of a warm handoff is really helping hand them off to another help provider or agency, but not leaving them alone while you're doing that. There's an example of something that happened in the last year with one of our VA community providers. There was a veteran who met with one case manager, and that case manager was not familiar with this veteran. He had worked with someone else at the agency, but she was not familiar with him, and he was having a bad day. And he was saying a lot of the things here, some of the signs of suicidal thinking, some of the more concerning signs. He was saying things like, I want to end it all, and I just can't deal with this anymore. They were very, very clear signs that he was in extreme emotional distress. Now, understandably, she did not know him, and it's totally understandable for anyone to feel uncomfortable in maybe engaging in that conversation directly with that person more. It may feel overwhelming. You may feel like you don't know what to say. And that is totally okay. And we're going to talk about some ways to warm handoff if needed. In this situation, he was saying all these things, and she knew that one of her coworkers was more familiar with this veteran, and that coworker worked maybe 5 or 6 blocks away. And she suggested that he walk to that person. And she just had him leave the office to go walk there. Now, gratefully, he did. He walked, and he went to that second location, but there was no heads up to that second provider that he was coming, and she also wasn't there. And nobody at the agency knew why he was there. And so he presented, was told that so-and-so wasn't there, and then he left. And he doesn't have a phone. He's in this real heightened state of emotional crisis and just wandering downtown Indianapolis. And provider number 2 was, of course, in distress when she heard about it 30 minutes later and tried to find him and could not find him. Luckily, a week later, he was located and he was okay. But it definitely could have not been okay. And so we definitely just want to reflect on a situation like that and think about how important it is to do a warm handoff. It was perfectly okay that provider number 1 maybe didn't feel she was the best person to talk further with him. That is okay. But the best thing is just as much as you can, keeping that person with you, making the phone call to the person that you're trying to warm handoff to. And let's say person number 2 wasn't available. We have here, and I have cards on the table about the Veterans Crisis Line. Just know that that number 988 is also the National Suicide Crisis Hotline. We just have a prompt, number 1 for veterans to press so that they can speak with the Veterans Crisis Line. But 988 is a number that anyone can call, whether it's an individual experiencing suicidal crisis or it is someone who is concerned for someone else. You can call on behalf of someone. So that is always, I feel like, a backup option if you feel, aside from calling 911, if there's a true threat, we definitely want to consider that as well. But 988 is another option of where you can have a trained crisis responder on the phone. They can also initiate welfare checks as well. And you just have to use your judgment with how willing it seems someone is to stay and either make that phone call or talk further with you. If they're not, and there's a real crisis happening, then 911 is always the option to do to get help for that person. So just some reminders when you're talking with a veteran or anyone at risk for suicide. You want to remain calm. You want to listen more than you speak, and this can be really hard sometimes, especially when someone is in a heightened state of emotional distress. This can be distressing for you as well when you're talking with them. And different people deal with distress in different ways, but some people nervously talk, and they struggle with silence, and they want to fill those gaps. For some individuals, when they are in distress, some people are more likely to shut down. Not everyone. Some people will verbalize how they're feeling, but others are more likely to shut down. And it takes more space for them to have the courage to maybe say what's on their mind. Maintaining eye contact and acting confidently as much as you can, even if you may not feel that way, presenting with that confidence and at the very least that caring attitude that you are confident that you care about them. Using the open body language, being supportive with encouraging comments, and also be honest that there may not be an immediate solution, but what you can connect them to is that help to start helping them address the feelings and the issues that they're having. So this is just a reminder of those steps of SAVE, the signs of suicidal thinking, asking the question, and remember to asking it openly and directly, validating their experience and encouraging treatment and expedite getting help. Just a kind of show of hands, I'm not sure where you all work, but in your workplaces, do you know if there's a policy or procedure of how to assist someone who's at risk for suicide? Yes. Anybody else have that? I know we do at the VA. You guys, yeah, I imagine. VSOs, do you guys have anything? Well, hey, I'm glad you're here. Maybe something we can talk with the DVA about a little bit. Yes?
Do you mind if I actually share a story about 98?
I would love it.
Okay. So I'm Jennifer, and I work on the mobile crisis response team here out of the Stride Center. And I love to see that you had a 988 slide up there. 988 did contact our mobile crisis response team because they had a veteran on the line that needed in-person assistance. So we were able to do a warm handoff with 988 staying on the line, our team arriving to the home, and then the veteran agreeing to go with the team to an inpatient facility. So this is really awesome to see this training, but also it was really encouraging to us that the 988 sort of referral system worked here in our local area as well. Yeah. And our veteran did request our responders to stay at the inpatient facility for additional support, which they were willing to do until an admission was accomplished for their safety. So I just loved seeing that up there and wanted to share that.
Thank you. Thank you for sharing that. That's a really good example. I love to hear that of an example of it working and connecting with the local community. Okay, so we're getting ready to wrap up here, but just talking about some resources and references. And if it works, I have a short little video I can show you. So the training that I'm doing here today, there is technically an online option. Not as much fun to do it at your computer versus going out in the community and getting a nice lunch. But technically, if there's anyone that you feel would benefit from this training and they can't make it to an in-person training, it says there about a 25-minute course, and they can get all of these same resources and direction on how to use the SAFE techniques through an online module. And then again, the 988, so this is the Veterans Crisis Line. Essentially anyone can call 988, but when a veteran calls 988, they press 1 and they get connected to the Veterans Crisis Line. So this is for veterans and service members, but also family members and friends. Sometimes we have concerned parties that call in. It could even be a community member or someone who saw them in some public setting and they had concerns, and so they called in. So this is just a little bit of information. I'll let you look through that. It's just showing how many calls that our Veterans Crisis Line receives and how the program has really grown since it started in 2007. And they've just expanded as far as the number of staff because the demand is there, and there are a lot of people calling in. People can also chat. So maybe they don't prefer to talk how they're feeling. They can send a chat in and have an online written communication with somebody and get resources and get connected to help. So this is a slide looking at local VA suicide prevention centers and different resources. So you see the website there. And I think these slides are going out. Is that right, Tatiana? Okay. So these slides are going out, and so you'll have access to connect to this website if you want to take a look and see what all this website has to offer as far as resources go. And just more information about the resource locator. Another website that has a lot of good information. These are all VA-sponsored websites. However, I imagine that there are a lot of broadly applicable resources on here if you don't work directly with veterans, but you just want some good resources on how to help individuals you might come into contact with. These are really good, and the VA puts a lot of time and money and person power into developing these resources because the risk for veteran suicide is so great. But all of the work that they're putting into developing these resources is just good for everyone to know about if you want to learn more about suicide and suicide prevention and how to connect people to help. So here I'm going to try to play this video. It's a short 3-minute video with some veterans talking about this Make the Connection. You see here, it's an online resource featuring hundreds of veterans telling their stories. This can be inspirational to a veteran or any individual that might feel more encouraged by hearing someone else who is a peer who has had a challenge and overcome it. So we'll see if the sound works. If it doesn't, you can go to this video later.
I found myself in a pretty dark place for a pretty long period of time, and just feeling sort of trapped in a way. just not knowing exactly what I should do next. I was sort of at my wit's end as to what was my purpose in life.
I mean, coming back, the switch was off. It had an impact on all my relationships, all my family relationships. I couldn't even. I was wondering if I ever had grandchildren, could I love them, because of, the disconnect.
I'd also submitted my work that I did in Iraq for Military Videographer of the Year, and I'm standing there, and all these people, the pinnacle, like, I am the best. I just became the best. I felt absolutely nothing and completely dissatisfied with the whole experience.
I had a few hobbies. It was mainly like auto repair and racing, maybe dirt bike, stuff like that. And that stuff, I tried it when I got back, and it just didn't give me any excitement.
After a 21-year career in nursing, I got to the point where it was hard for me to get out of bed every morning. I was lethargic. I had anhedonia, which means I had no pleasure from anything that I did. And I had suicidal ideation, and I had a little bit of a plan to turn around and, walk in the front of a car.
I went from being super active, doing everything around the house. Now for 12 months, I was more of a burden on my family, and I just kept feeling more and more worthless. And that's when I contemplated starting to take my life.
This friend of mine who was a veteran introduced me to the group. There was a different connection, a different understanding about what was happening. And that is what began to make the difference for me.
I talked to the psychiatrist down there, and then she recommended me to they have like an outpatient psychiatry department down there. So they recommended the medication, and then I did like one-on-one counseling sessions, and I've been doing it ever since.
One day, one of my kids said something to me that, made me realize I need to get help. I need to be there to help them. The VA crisis line was the first place I called, and then I started trying to meet with a counselor.
It showed me that regardless of my medical problems, a lot of the limitations that I felt were limitations I just placed on myself. That I could still enjoy a lot of the same activities that I did, just in a different way, and get the same result.
I would say for the last 5 or 6 years, not only have I not had depression, but I've also been happy. After
I started seeking the help, the work performance started to increase again. I started believing in myself and started getting more confidence. It was a lot easier to do my job, do daily things.
You got to reach out. You got to put your hand out. You got to make the first step, and that's the hard one, is the first step.
Know that there is a way that you can get help. There is a way that you can deal with some of the difficulties related to your war experience. Look at it as a community of people who want to help. I think that has felt different for me, and to keep at it until you make the connection.
All right. So the one thing I like about hearing those stories, sorry you couldn't see their faces, but that's an example of a video on this website, and this website has many videos and lots of veterans telling their story, and it's an opportunity to connect either a supporter or someone who's struggling with emotional challenges with information and solutions. So this website here, you can connect to that when you get the slides. And I'll share a little bit of a personal story that I had long before I worked at the VA. But there was someone who was friends with somebody who I knew, and that person called me and that other person, and they were randomly, I don't know why or how, they were backpacking in the woods in a remote location in some other state somewhere. This was someone that we knew as a friend, and they had a gun, and we couldn't tell exactly what their intentions were, but it did not seem good, and they were very depressed, and the phone got handed to me. And I didn't have all the training that I have now, but I was concerned for them and talked through what they were going through where their head was at that time. And ironically, I didn't think about this when sharing this story. This is someone we're going to his wedding in about a week, and this was probably about 15, 20 years ago. So this was a really low point for that person who's gone on to be successful and build a lot of things in their life, who was at a very low moment at that time. And talking with us potentially was life-saving. I don't know for sure, but unless you try and reach out and show that compassion for someone, you'll never know. So you never know when these opportunities are going to come up, either with people that we work with in our jobs or with people in our lives. And just some more resources about practicing safe storage. And this is the brochure that I printed off. It's out there. If you like to have things tangible, you can take that with you. And just a reminder that we want to support everyone who might be at risk of suicide, including members of the LGBTQ plus community. And every VA facility, including in Indianapolis, we have an LGBTQ plus veteran care coordinator. We actually have a great program in Indianapolis, and that person who took that position has been on national calls and really kind of paving the way for this newer program that's come out at the VA in the last several years. There are so many great apps. So if you have anybody who is tech savvy, these were developed by the VA, but somebody who is not a veteran could use them. If they are perhaps a younger person, someone with a smartphone who has access to a smartphone, there are great mental health apps, ideally used in conjunction with therapy. But if this is someone who is not likely to follow through with therapy, there are some great opportunities to access things at your hand. I've even heard, I'm not sure if it's on here, but there's a way to do a safety plan on an app. And it's really great for someone who is tethered to their phone to have their suicide prevention safety plan on their phone, and to be able to access that at any time is a great tool. Oh, hey, there, I forgot that was the next slide. Safety plan app. So there you go. So that tells you how to download that. So with the Safety Plan app, you can create a custom step-by-step action plan to keep yourself safe during a crisis, make a list of your own personal reasons to live, and also add photo and video reminders just to make that more personal and tangible, listing different coping strategies to try, and also some crisis support resources. So just as easy as you can access your Facebook and your email, Instagram, you can click on your Safety Plan app for someone who maybe is at more risk of that, and have that very accessible and personalize it the way that is important to them. So another important issue is called postvention. So this would be if there is a completed suicide. Our suicide prevention team does engage in postvention counseling. When we have a veteran connected to our medical center that has completed suicide, they always offer that. If that ever happens in this community, definitely let me know if there's anything I can do to connect you all either through the VA or some other resource to postvention. And there's also just general, this is discussing also general consultation resources that are available. And just let me know if you want connected to anything. I know we've asked this question before. We have community providers who aren't VA employees, but they work with veterans. We've asked before if they would have access to some of these consultations. And as long as they're working with veterans, so this would be more specifically if you are working with a veteran, our community partners we can look at getting you access to these resources as well. And then more about postvention, and then the SAFE training. Any questions? That is all that I have today for the formal presentation, but does anybody have any thoughts, questions, reflections, or any scenario or experiences you think might be helpful to share? Mary?
You may have touched on this, but I'm wondering if there's a certain age demographic that's more likely to have suicidal thoughts. They're veterans. I know that I've had conversations with folks at the American Legion, and they have a hard time reaching younger veterans.
Okay.
And I don't know if that is that community building is like not happening for younger veterans, and that puts people more at risk. Or I'm just curious about that age difference, if there's any insight there.
I don't have any data on that, so I don't want to speak to it without knowing what the data is. I would say that sounds accurate, that younger veterans are more likely to be less connected to healthcare. The VA has done a huge push, especially in the last couple of years with the passing of the PACT Act, to get out and enroll as many people as possible. But we do have an older demographic at the VA, which I think is changing, but I don't know at what rate that it's changing. But yes, if it is someone who is not connected to healthcare, who's a veteran, connecting at any level, whether it's with a veteran organization like the American Legion, where maybe they were first identified, but also going more grassroots than that with other local community organizations, anything to do to build in that extra layer of support and connection so that there's a framework there. And then, you can always build off of that and help connect to all of the resources that the VA has to offer as well. Scott?
I also want to say it's not always widely known, but actually the highest risk of suicide are in our elderly population, those like 78 and older. And so in particular for veterans, they're already a vulnerable population. So taking that into account as well is really important and engaging them. So some of this technology and stuff is really great in engaging the younger folks in prevention, but what can we do to better engage our older population as well?
Mm-hmm. Yes, Steve?
I noticed that you didn't mention the Compact Act, the ability for veterans who are in acute suicidal crisis to go to emergency rooms. Is there anything that you can tell us about the Compact Act and how that might be beneficial?
I am not prepared to speak on that, though I know of somebody who goes out and does presentations on the Compact Act. So if that's ever anything that we want to have a separate presentation on, she's with the suicide prevention team. It's a new position that was created within the suicide prevention team that is fully focused on the Compact Act. And so she does do that presentation. So whether we did it in a venue like this, or if Steve, you wanted me to connect you with her for her to come down to your office and do a full presentation on everything Compact, we can work on that. Yes. Thank you for bringing that up.
This is just a minor thing. You use the word completed suicide. I typically say committed. Is that a change in terminology that, I don't know, can you just speak to that? Is that something that...
Yeah, so there's a real differentiation when we're talking about veteran suicide history, whether someone attempted suicide and what level of lethality with the method used that was used. So we're assessing that. And a completed suicide is just the official term for someone who has passed away and who has died by suicide. But there are a whole continuum of different levels of risk leading up to that, where if someone has not died by suicide, Even if they have attempted suicide even multiple times, there's always opportunities to intervene and provide help. So that's just the term that we've been taught at the VA is completed. Yeah. Yes.
So what should we do if the person you are working with displays hostility or hostile attitudes towards the police? If you might have to call them, or medical treatment due to past trauma or other kinds of harm.
Yeah. So are you talking about someone who is expressing thoughts of suicide and they have hostile feelings towards the police, and you're thinking about connecting them to crisis services and not sure how that's going to go? Are you in Bloomington? Yes. Okay. So some folks here, maybe Jennifer can speak to this a little bit more. I know that a lot of communities are building in supportive response systems for these exact situations. So do you want to talk a little bit about what you would do in that situation?
So we have a Stride Crisis Center that is open 24/7, 365. So if it is an option for you to help them get there safely for in-person support, that is a non-medical setting and a non-law enforcement intervention you could consider. So as she was talking about warm handoff, if you want to be the warm handoff to the crisis center and the person's open to doing that with you, that's an awesome idea. If they're willing to accept in-person support, but they would prefer that it not be law enforcement, then you can also call the Stride Crisis Center and you can ask for our mobile crisis response team to come out in person. We will advise you to remain with the person until we arrive for, again, a warm handoff for their safety, and then we'll respond with 2 in-person responders. And the Stride Center and the mobile crisis team are available 24/7, 365.
Cool, thank you.
Piggyback off of that. So I used to work as a first responder, and I've used the Stride Center a lot with folks that we've helped out. My question for you to kind of piggyback off that, formerly working out in the county, is there a limit to how far your mobile responder will go?
No.
And
No.
has this been communicated to like sheriff's office, ISP?
Yes.
Cool.
Yes.
That's good.
We currently, on our hub, serve 5 counties.
Okay.
And we absolutely go out in the county. We've been partnering more with Monroe County Fire on some scenes recently too. So,
Awesome. Thank you.
I was just gonna add, in the instance, we co-respond with them too. So in the instance that you're also worried about maybe something, we're all at minimum EMTs, so we can medically assess too, but we don't, it's less threatening, obviously, our team coming to them. And we've been through like mental health first aid and critical incident stress management and a whole gamut of things. So it's really cool when that works really well together.
Shelby, can you say who you work for?
Oh yes, I'm so sorry. My team here, we're the mobile integrated health team at the fire department.
Cool. Yeah, I've never heard of that before.
Awesome.
Good question. Thank you. And thank you all for sharing what you do.
I have cards out on the table for Stride and Mobile out there.
Awesome.
So, excuse me.
Yes.
Like, we have our veterans meeting 6 to 7, now that I'm 10, and I'm not sure who would be the person that we would contact if we were having veterans in trouble.
Can you share with me who you're connected to?
I'm Vet to Vet here in Bloomington.
Oh, okay. Wonderful. So you have a Vet to Vet group, you host a Vet to Vet group? Yeah. So are you thinking if something came up in the group environment?
Yes, because, we just have a room full, so.
Yeah.
I don't have any associations there, really, besides the secretary.
Do you have more than one person that facilitates the group?
Sometimes.
Okay. If you have the luxury of having a second person, I think it'd be good to have some of these discussions with your co-facilitator ahead of time. If there was a situation that arose where someone seemed like they were in acute distress, make eye contact with that person, whoever is the best person to step out with them, and maybe separately talk with them and assess further and help connect them to help right away. If it is a situation where you do not have a co-facilitator, I would just ensure to the best of your ability that you can talk with them at the conclusion. If you have a real concern, you can pause group. Vet to vet, I imagine they can function independently for a little bit, and maybe just casually see if they're willing to step outside with you and let the group continue while you assess further with them. If it seems to be more immediate crisis, you can call 911 if they're willing to do that. Call 988 and stay there with them while they're making that call. Some of it depends on the seeming urgency of it, of how acute that it is.
Yeah, she did say 24, hours, so, yeah.
Yeah. I mean, that's an option to go to that crisis center as well. Obviously, emergency rooms as well. They evaluate suicide risk very commonly. That is a common location to take someone if they are at risk of harming themselves, and they can connect that person to residential treatment if that's what's seen as best, so they can get that help while they're in that crisis.
Thank you.
Yeah.
I just.
That's a good question.
For a second, I did what should I do?
Yeah, no, thank you for asking. It's good to hear. I mean, everyone's coming from a lot of different places, and so it's wonderful to hear how you can take this information to where you all are working and implement it.
The Stride Center has snacks, right?
Sometimes we run out.
Uh-oh.
That was a great selling point.
Yes, we do have snacks, we have showers.
The shower's not so much point for now.
Yeah.
I think what's cool is you've got a lot of people here that while we don't all, our primary work might not be with veterans, we all really do work together for a common response. So I think that's really unique to our community.
Yes.
So I love this. I thought this was a great way to talk about it. I think continuing to talk about it, it's just like practicing our skills.
Absolutely.
We're just going to keep getting better at it. But something that here, it's unique that we do work together.
Yes. And I don't know what all suicide prevention training your agencies individually have, who you work for, but we at the VA, whether it's myself or we have some community engagement workers with our suicide prevention team, there are multiple people at the VA that will perform or engage in these SAVE trainings. So as often as you want me to come back here, or if there's anybody at an agency where you feel like more of your staff would benefit and you want me to come to you, more than happy to do that. We like to get the message out to as many people who are willing to hear it as often as they're willing to hear it. So thank you so much all for being here. I really appreciate it. And I told Tatiana 30 minutes. I don't know why I thought that. It's like 1:30 right now. So, but thank you all for coming and appreciate you.
Yes, thank you, Jessie, for shedding a light and reminding us that suicide is preventable, and that each of us have a role to play in making sure people feel seen and heard and cared for. So thanks for joining us today. If you want to learn more about heading home or connect with Jessie, please feel free to reach out to myself or Mary and Jessie while she's still here. Thanks, everyone. Have a great week.